guys on the right format of the presentation. Good morning, and thank you for joining us. I hope you enjoyed the presentation given earlier by our colleagues Kate Gilliard and Alice Bell. Hold on just a second. Sorry about that. Give me a sec. Great. So, and just a quick note on their presentation on the PTA differential slide. I wanted to clarify that the SMART Act would require general supervision of private practice. So while Kate mentioned this in the audio, the slide said direct. I just wanted to clarify that. So our presentation will focus on some regulatory and legislative issues not discussed previously. So today's speakers include myself. My name is Steve Postal. I'm the Senior Specialist of Policy and Regulatory Affairs at APTA. And I'm joined by my colleague, Brian Allen, who is a specialist in congressional affairs. So first off, a regulatory update. But before I delve into updates, I first wanted to discuss our regulatory advocacy generally. So APTA helps to shape regulatory actions by providing information and expertise to federal agencies. So while Brian will discuss legislative advocacy, regulatory advocacy focuses on the executive branch of government, administrative agencies, and the regulations that they put out. APTA engages in regulatory advocacy by meeting with federal agencies, including some of those shown on this slide, and submitting formal recommendations for their consideration when they publish proposed rules and when they seek public comment. So we also seek out opportunities to engage with regulators on behalf of the PT profession to build relationships. This allows us to educate them about the role that PTs and PTAs play in the healthcare delivery system and to advocate for policy change. But APTA can't be the only one who engages with federal agencies on behalf of the profession. It is critically important that PTs, PTAs, and students engage in regulatory advocacy. A great deal of significant change can result from the regulatory process, particularly by sending comment letters during open comment periods. By submitting comment letters in response to proposed rules, PTs, PTAs, and students have the unique opportunity to share their expertise and advocate for their patients in the PT profession, and also to educate regulators. This is a very important way you can share your voice on issues that impact the profession, patients, and the care that furnished by PTs and PTAs. So we try to make it as easy as possible by posting unique template letters to our Regulatory Action Center page that can be used to submit comments to federal agencies that have open comment periods. In addition to meetings and submitting comment letters, another key component of advocating for the PT profession is by nominating PTs and PTAs to serve on a wide variety of federal agency advisory committees and task forces. By having a seat at the table, it ensures that PT's profession's voice is adequately represented, as these committees discuss and consider policy changes that could have a lasting impact on the healthcare system, including on PTs and PTAs. We encourage members to visit the APT Engage webpage and for those federal committees and task forces that they may be interested in being nominated for. We need a bench of expertise to make timely and competitive nominations. So now I'll turn to some regulatory updates. To start us off, I wanted to discuss two developments in the durable medical equipment, prosthetic, orthotic, and supplies category, or DMEPOS. So while not directly related to physical therapy, these could have an impact on care. So the first update, on January 13th, CMS issued multiple updates related to the Healthcare Common Procedure Coding System, or HCPCS, related to the master list of DMEPOS items that require prior authorization, face-to-face encounters, or written orders. The announcement also includes items CMS has deleted from its master list. Items in the update include dressings, pneumatic compressors, several types of neuromuscular stimulators, manual wheelchair accessories, power wheelchairs and parts, and multiple orthoses. The update will be effective April 13th, with prior authorization phased in over different states from April 13th through October 10th, and then national implementation starting on October 10th. So for details, please see a story we did on the updates on our website. So for the second DMEPOS update, in late December, CMS issued a DMEPOS final rule effective on February 28th of this year. In this rule, CMS added a streamlined process for making benefit category and payment determinations under Medicare Part B. CMS decided to hold off on proposed revisions to the HCPCS Level 2 application process. So for some clarity on this, first, in the final rule, CMS established procedures to include public consultation before making benefit category and payment determinations for new items and services that are DME, orthotics and prosthetics, therapeutic shoes and inserts, surgical dressings and splints, casts, and other devices. Secondly, CMS held off on its proposed HCPCS Level 2 applications process changes. CMS had proposed changes in how it adds, revises, and discontinues HCPCS Level 2 codes, and they would have codified shorter and more frequent cycles for coding applications and shifts and processes for reevaluating these coding decisions. But the final rule puts the brakes on any changes. According to CMS, the decision to hold off was made in light of several administrative improvements to the coding editorial process that addressed many of the issues highlighted in the proposed rule. So the agency added that it will continue to evaluate coding processes. APTA supported greater transparency of and reforms to the HCPCS Level 2 applications process in comments to CMS. And now turning to Medicare Advantage. On January 12th, CMS published its annual proposed rule on changes to Medicare Advantage, and we submitted comments on March 3rd. So CMS is proposing to specify that the maximum out-of-pocket limit in an MA plan is calculated based on the accrual of all cost sharing in the plan benefit, regardless of whether the cost sharing is paid by the beneficiary or any of the payers. So APTA supports this proposal as it allows beneficiary to hit their maximum out-of-pocket limit quicker, effectively reducing the out-of-pocket expenditures shouldered by beneficiaries. Also, to improve transparency, CMS is proposing to reinstate detailed medical loss ratio reporting requirements that were effective for contract years 2014 through 2017. So these required reporting on the underlying data used to calculate and verify the MLR and any remittance amount, such as incurred claims, expenditures, or any other costs. So APTA strongly supports this proposal and encourages CMS to further promote transparency around QIAs through this and future rulemaking. However, we questioned whether utilization management programs are quality improvement programs intended to ensure appropriate treatment. We recommended that CMS review all activities currently considered QIAs so that we're making sure that they're actually increasing quality and not merely cutting insurers' costs. And also in fraud reporting, APTA expressed concern that CMS is removing the cap on fraud reduction expenses used in QIA. And that as an unintended consequence, these insurance companies will abuse the lack of a cap, and thus they'll submit significant amounts on unrelated audits in the name of fraud reduction expenses. So APTA advised CMS to further define fraud and fraud reduction expenses so that the issuers could more narrowly target their audits. And lastly, APTA recommended a host of prior authorization reforms in MA, including that CMS require MA plans to use the same standardized request form for prior authorization, to accept requests through the same submission mechanism, such as through a provider portal, and also to adopt a required response period for prior authorization and repeat authorization requests. So now turning to our opioids advocacy, SAMHSA convened a substance use coordinating committee on March 16th, and we submitted written comments ahead of this public meeting where we addressed recommendations in improving programs for treating and recovering from opioid use disorder. So we submitted comments on a number of issues, and these included the promotion of non-pharmacological alternatives to opioids and that they must include physical therapy. We also recommended that SAMHSA advise HHS to include PT within the definition of federally qualified health centers and rural health clinic services. We recommended that SAMHSA advise CMS to evaluate how payer benefit design can be restructured to promote direct and early access to physical therapy. And lastly, we recommend that SAMHSA advise CMS to require physicians to work with the beneficiaries' prescribers to develop a non-pharmacological, multidisciplinary pain management treatment plan that would, of course, include PT. So in another opioids-related comment opportunity in February, the CDC published a notice on its new 2022 proposed clinical practice guideline, or CPG, for prescribing opioids in pain treatment. So comments for this are due on April 11th, and APTA will submit comments. So this CPG is an update of the 2016 CPG and provides evidence-based recommendations for clinicians who provide treatment for acute, subacute, and chronic pain. The CPG includes recommendations for not only primary care physicians, but also for outpatient clinicians in other specialties. So the CPG is voluntary and is meant to be flexible to account for clinical judgment as well as patient-centered decisions. APTA is currently advocating in several comment opportunities dealing with interoperability. And as you'll see in the next few slides, we are basing our efforts on advocating for the implementation of what is known as the ICF model. So the ICF model stands for the World Health Organization's International Classification of Functioning, Disability, and Health categories and subcategories. It was approved in 2001 by the World Health Assembly as a framework for describing and organizing information on functioning and disability. So APTA adopted ICF in 2008. As discussed in ICF, functioning is a dynamic interaction between a person's health condition, environmental factors, and personal factors. Most relevant to PT, an element of the ICF focuses on activities and participation, with subcategories including mobility. The ICF concepts are taught in PT education programs, they're included within licensure exams, and they form the framework for current PT clinical practice. Multiple studies have demonstrated the strength of ICF for classifying functioning and disability. APTA has long endorsed ICF and uses it to develop evidence-based practice guidelines that will enhance the profession. So far, we've produced at least 17 clinical practice guidelines based on ICF. So one opportunity that APTA is advocating for the increased adoption of the ICF model is in comments that APTA just submitted to the Office of the National Coordinator for Health IT, or ONC for short. On January 24th, ONC published a request for information, or RFI, on prior authorization for health information technology. Specifically, this RFI seeks input from the public regarding e-prior auth standards, implementation specifications, and certification criteria that could be adopted within the ONC Health IT certification program. Responses to this RFI will be used to inform potential future rulemaking. APTA's comments focused on the impact of providers and PT specifically. So our comments, among other things, addressed, first, The need that ONC adopt the ICF model as a framework for classification of health and health-related domains within certified EHR technology in order to further incentivize PTs to effectively use prior auth. But we also advocated for appropriate resources and support, including implementation assistance to PTs as they adopt and optimize certified EHRs. And we asked for a transition period of 3 to 5 years for implementation. Additionally, our comments stress the need for standardized processes for prior auth among all public payers and contractors, as well as standardized processes for billing and post-care documentation requests. We also advocated for a long list of additional prior auth reforms, including outlier management and the exemption of routinely authorized visits. A second opportunity that APTA is advocating for the increased adoption of the ICF model is in comments to ONC's US CDI draft version 3. So comments on this are due in April 30th. So the United States Core Data for Interoperability, or USCDI, is a standardized set of health data classes and data elements for nationwide interoperable health information exchange. So the first version of USCDI, or USCDI version 1, is adopted as a standard in the ONC Cures Act final rule. The USCDI sets a foundation for broader sharing of electronic health information to support patient care. So the data element is the most granular level at which piece of data is represented in the USCDI. The data class, on the other hand, is an aggregation of various data elements by a common theme. So for example, in the current draft USCDI version 3 up for comment, if you look at this slide in the top right-hand corner, health status is the new data class. And this represents health-related matters of interest, importance, or worry to a patient, patient's family, or patient's healthcare provider. The data elements that fall within health status includes functional status, disability status, and others. So as currently drafted, the functional status data element currently represents assessments of a patient's capabilities or the risks of development or worsening of a condition or problem. APTA's comments are focusing on the functional status data element, and namely to advocate that it model the ICF more precisely. And a third opportunity that APTA is advocating for the increased adoption of the ICF model is in APACIO's project's new Cognitive and Functional Status Implementation Guide, or IG. So the APACIO project is a collaborative effort to advance interoperable health data exchange between post-acute and other providers and patients. The primary goal of the APACIO project is to establish a framework for the development of IGs that can assist in health data exchange. So one of these implementation guides deals with cognitive and functional status. And APACIO published its first version of separate cognitive and functional statuses IGs late last year. APACIO is currently discussing publishing a second version of the guides, which will likely be a joint unified cognitive and functional status IG. APTA has submitted comments on elements that it believes are most important on the functional status side, and a more formal comment process is currently slated to occur at some point in the third quarter of this year. But in short, we'll be advocating for the framework of this guide to track with the ICF model. So I wanted to give a quick update on information or info blocking developments. But first, I think a bit of a background is warranted. So in 2016, the 21st Century Cures Act, or Cures, was signed into law. And this included a prohibition on info blocking, and they directed HHS to issue regulations. This was followed by info blocking regulations published in May 2020 by the ONC, which is a division of HHS. A practice may be considered info blocking under the info blocking rule if it is likely to interfere with access, exchange, or use of EHI, and if it meets the applicable standard. depending on the actor. Compliance with the info blocking regulations began on April 5th, 2021. So EHI is defined as the Electronic Protected Health Information, or EAPHI, and is a designated record set as defined by HIPAA, regardless of whether the actor is a covered entity. The designated record set in a practice typically includes medical records and billing records about individuals, but also other records used by the healthcare provider to make decisions about individuals. However, until October 6th of this year, EHI is limited to the data elements represented in US version 1. But on October 6th and after, the definition of EHI expands to that of EPHI. At that time, actors will be required to make their patients EPHI available for access, exchange, and use. So the info blocking regulation governs three categories of actors. There are the health IT developers, the health information exchanges and networks, and also the healthcare providers. A healthcare provider includes a wide range of providers, and it includes therapists, home health agencies, skilled nursing facilities, and others. The info blocking knowledge standard varies based on the type of actor. So for healthcare providers, the standard is that the actor knows that such a practice is unreasonable and is likely to interfere with, prevent, or materially discourage access, exchange, or use of electronic health information. Actors regulated by the info blocking rule are not regulated based on what type of entity they are, but rather they're based on the capacity in which they are acting. So an important ramification of this is that a healthcare provider could be regulated as a network or exchange based on its practice at issue. So thus it's critical to understand which hat an actor is wearing, because the capacity in which an actor is acting can determine the standard that applies and the applicable penalties of a violation. So while HHS states in its regulations that there will be appropriate disincentives for providers that are engaged in info blocking, the details on what those might be have yet to be fleshed out in regulation. But info blocking can occur in many forms. Providers can experience info blocking when trying to access patient records from other providers, connecting their electronic health record systems to local health information exchanges, or for migrating from one EHR to another. It can also occur in more subtle ways, such as through contract terms or organizational policies. So some examples include an organization's policies that prevent sharing or limit how information is shared with patients or their healthcare providers, or healthcare providers or IT vendors limiting or discouraging shared information with other providers or with users of other IT systems. Patients can also experience info blocking when trying to access their medical records or when sending their records to another provider. Now, with such a broad definition of info blocking, Congress directed ONC to identify activities that were valid reasons to restrict information access. So ONC identified these 8 exceptions to ensure reasonable and necessary activities wouldn't be mischaracterized as info blocking. So these exceptions allow providers, developers, and health networks to comply with legitimate business practices. So on February 28th of this year, ONC released a study compiling info blocking complaints. According to ONC, most of the complaints came from patients and were predominantly aimed at providers rather than at health IT developers or other stakeholders. The report reveals that while there hasn't been many complaints so far, among the 299 received, nearly all of them, at 274, were deemed to be on target as claims of possible info blocking. An overwhelming majority, or 176, of the complaints were registered by patients. Healthcare providers were the targets of the most complaints at 211. So for more details on the HHS report and APTA's information blocking resources, please see our story on our website. In addition to other resources, our website includes a practice advisory that APTA issued soon after the rollout of the rules, which includes background on the issues, some definitions, compliance tips, and links to HHS resources. And just real quick, the next couple of slides of my presentation, and you have these in your materials. There's some further resources if you are interested in more deeper dives in what I discussed, both on our regulatory advocacy, the articles on DMEPOS, and information on the ICF model. And then lastly, on the US CDI, as well as some of our resources on info blocking. And before turning it over to Brian, happy to take any questions. Any questions? Did you guys not see my slides that whole time?
We were able to see him, Steve.
Okay, cool, good. I'm still figuring out this Zoom. Perfect. Yeah, having no further questions, I'm going to go ahead and turn it over to Brian, and we'll break again for further questions after his presentation. So let me just give me a second to get that up, get that.
All right, perfect. And Steve, thank you so much for the introduction and the transition. Let's just go ahead and start with an overview of the federal government. So, as Steve mentioned, my name is Brian, and I am a Congressional Affairs Specialist with APTA. Today, I'm going to start by providing you with an overview of the federal government and the legislative process. I'll then talk about APTA's advocacy efforts and several of our top priorities during the 117th Congress. First, I'd like to go back to the civics class you likely took in high school and talk a little bit about the state versus the federal government, since I know that you all are actively involved with both. Under the US Constitution, all 50 states are known as separate sovereigns. That means that unless preempted by the Constitution or another federal law, states have control over their own affairs. This dual sovereignty affects how certain programs are controlled. For example, although Medicare is funded by the federal government, although Medicaid is funded by the federal government, the states are in charge of administering it. The federal government, on the other hand, administers Medicare directly. Now, throughout the rest of this presentation, when I refer to the government or Congress or the legislature, I'll be referring to the federal government. So, building off of that, our government has three branches. The first is the legislative branch, comprised of both houses of Congress, the House of Representatives, and the Senate. As this is the branch that makes laws, this is where most of my team's advocacy is focused. The second is the executive branch, comprised of all federal government agencies, such as CMS and HHS, and headed by the president. This branch is in charge of enforcing the laws passed by Congress, often through regulation. While our team may interact with agency officials to advocate for change behind the scenes, this is typically the branch Steve's team is more likely to interact with. Now, the third is the judicial branch, comprised of the federal courts and headed by the Supreme Court. This branch interprets laws and regulations, determining whether they are constitutional. We don't typically deal with the courts very much in our day-to-day advocacy, but their decisions could have a fair amount of effect on us. Now that we've briefly discussed the three branches of government, I'd like to give you all a refresher on what drives much of our work here at APTA, the legislative process. So, legislating begins with an idea to address a concern with the federal government. These ideas could come from the member of Congress or senator themselves, their staff, an interested group like APTA, or a constituent, just like yourselves. Once a congressional office has an idea to make into a bill, their staff will work with a group of nonpartisan lawyers called legislative counsel to turn the idea into bill language. After this is done, the member or senator introduces the legislation by filing it in the Capitol. The new bill is then assigned to committees of jurisdiction, and this could be more than one committee at a time, depending on what the bill covers. And when I refer to committees, I refer to specialized groups of members and senators and their staff who are heavily involved in particular federal issues, such as Medicare. These committees have oversight responsibilities over federal agencies as well, such as CMS. Now, the committees we most commonly work with are the Ways and Means and Energy and Commerce committees in the House and the Finance and Health committees in the Senate. Now, once a bill comes before the Committee of Jurisdiction, it might be subject to a hearing, which is a formal discussion on the record of the legislation, and or a markup, where the content of the bill is debated prior to its approval by the committee. In markup, amendments may be added, words may be changed or taken out. This is where a lot of legislating occurs. Now, after the markup, the committee will have a vote on the bill, and if the committee approves it, it is then sent to the House or Senate floor, where the entire chamber votes on it. Bills are either voted under regular order, which is a majority in the House, or in most cases, 60 votes in the Senate, or under special circumstances. This could be a suspension vote in the House, where 75% of the House has to agree, or what's known as a unanimous consent or a UC request in the Senate, where a bill can pass if no senator objects to it. Now, after a bill is passed by one chamber, it's then sent to the other, where the process essentially begins again. And if both chambers pass the bill, it then makes its way to the president's desk. He may sign the bill into law or veto it, aka rejecting the bill. However, a 2/3 vote from both chambers may override a presidential veto. This process, not surprisingly, is complex and time consuming. It typically takes the average bill between 2 to 3 Congresses or 4 to 6 years to be passed, if the item is passed at all. Now that we've had an overview of the federal government and the legislative process, I'd like to talk with you all about advocacy. First, the advocacy that we here at APTA do on your behalf. Our team is directly involved in actually crafting legislation alongside senators and members of Congress. This can range from providing input to ensure the legislation meets our goals to outright providing draft text. In order to do this, we work directly with congressional offices and committees of jurisdiction. Typically, the ones I mentioned earlier are Ways and Means and Energy and Commerce in the House, and then Finance and Health in the Senate. Additionally, we guide legislation from introduction to passage into law. Now, what do I mean by guide? When I use that term, I'm discussing the steps necessary to ensure a bill moves through Congress. Now, this could refer to just reaching out to member and Senate offices, asking them to co-sponsor a bill, working with committee staff to get legislation a hearing before the committee, helping offices draft letters to their party's leadership in support of legislation, and much more. In addition, we also endorse and promote bills that we may not have helped craft, but still meet our goals. This includes public endorsements, letters of support, and efforts to guide these bills, much like legislation we lead. In addition, part of these advocacy efforts is working with other groups who may share our interests. APTA is a member and a leader of numerous coalitions of professional organizations and other entities working together to promote key legislative goals, such as the SMART Act, which I'll chat about later. Aside from the work we do on our own, we also help coordinate your efforts. You can find action alerts on our social media intended to bring important legislative items to your attention. And we also keep you regularly updated through our advocacy website and our app. Now, I want to just take a minute to talk about recent happenings on the Hill and just to show you where Congress's attention is going to be for the near future. So, first off, as you all know, President Biden recently signed H.R. 2471, the Consolidated Appropriations Act of 2022, commonly referred to as the Omnibus, into law. Now, this $1.5 trillion spending bill will fund the government through the end of FY 2022. Most importantly for us, the legislation contains an extension of emergency telehealth waivers, which I'll talk about a little later in the presentation. Next, as I know you all know, Russia invaded the Ukraine several weeks ago. Now that the omnibus is passed and spending is taken care of, this is going to occupy the majority of Congress's attention, especially because it's going to dominate the news cycle for the conceivable future. Now, the final topic confronting Congress right now is President Biden's Supreme Court nomination. The president has nominated Judge Ketanji Brown Jackson of the D.C. Circuit Court of Appeals to replace Justice Stephen Breyer, who will retire from the court after its current term ends. Now, Senate Majority Leader Chuck Schumer has pledged to have Judge Jackson's nomination process completed by the end of April. That means that this process is going to dominate the Senate calendar for the next month. Now, these events signify that it's likely going to be a slow month on the Hill for health policy. However, that doesn't mean that there aren't opportunities to advance APTA's policy goals, nor does it mean we aren't working to do so. Although the FY 2022 Omnibus was just passed, it will soon be time to work on the 2023 Omnibus. And this is a fantastic time to advance APTA's priorities, including the PTA differential, and our bill to address this existential issue, H.R. 5536, also known as the SMART Act. Now, momentum on the SMART Act is building. We're up to 26 co-sponsors in the House and are continuing to work to add more. Additionally, a bipartisan group of SMART Act co-sponsors, led by lead sponsor Bobby Rush, recently sent a letter to House leadership in support of the bill. We are also working actively to get a Senate companion, a Senate version of the House bill introduced, and are in discussion with several interested Senate offices. I also want to draw attention to the fact that APTA has been and is leading on the SMART Act. Our coalition with AOTA and numerous other groups has been pounding the pavement to get this bill across the line. While we continue to promote the SMART Act itself, we're also looking for what we refer to as vehicles or larger legislative items in which we could insert the bill's text. This could be the FY 2023 Omnibus, for example. Additionally, on the regulatory side, APTA has been in talks with CMS about a regulatory fix to this as well, and those discussions are ongoing. Now, I'd like to talk about fee schedule cuts and actually share some good news. In December, Congress passed the APTA-supported fee schedule-related legislation known as the Supporting Medicare Providers Act, H.R. 6020, to offset the 2022 cuts planned by the U.S. Centers for Medicare and Medicaid. This legislation provided $3 billion in additional new funding to the 2022 fee schedule's conversion factor through the end of the year. In addition, the planned 2022 cut to PT was reduced from 3.75% to approximately 1%. It also reduced the plan 3.8% cut to OT and the 3.9% cut to SLP. Now, much of this was accomplished by the Fee Schedule Coalition, of which APTA is a leader, serving alongside the American Medical Association, groups representing orthopedic surgeons, and other groups. Now, we are already gearing up to fight additional cuts that could appear in 2023. And on top of this, we're working with our coalition partners to find a permanent solution to this yearly crisis. We understand how stressful this cycle can be and all the included uncertainty, and are looking for ways to, for lack of a better term, blow up PFS and establish a permanent, reliable pay for value model. Now on the telehealth, and here's where I have some of the best news to report. As I mentioned a little earlier in the presentation, the FY 2022 Omnibus was great for telehealth. It contained a 5-month or 151-day extension of emergency telehealth authorities given under the PHE once the emergency is declared over. Now, you all may have heard by now, but PT was explicitly mentioned as covered by the telehealth extension in the Omnibus. Now, we don't know when the PHE is set to end, but the length of the telehealth waiver extension has led us to believe it may end this July, which means that telehealth waivers would last until the end of the calendar year. Again, we don't know if that's the case. That's just supposition based on the timelines we have. Now, this 5-month extension provides us with an invaluable opportunity to work towards more permanent telehealth authorities, and we're constantly looking for opportunities to do this. The best chance to do so may be in an expected end-of-year healthcare package. However, as I'm sure you all know, having dealt with Congress, it's too early to know if this package is going to come together. Regardless, permanent telehealth authorities for PT remains one of our top priorities. Next, I'd like to talk a little bit about social determinants of health. APTA's social determinants of health legislation is S104, the Improving Social Determinants of Health Act. This bill requires the CDC to establish a program to improve health outcomes and reduce health inequities by coordinating activities across the CDC. As part of the program, CDC must award grants to eligible organizations to build capacity to address social determinants of health. Language from S104 is included in the Prevent Pandemics Act. Now, this is a Senate bill introduced by Health Chair Patty Murray and Ranking Member Richard Burr to take action on lessons learned from the COVID-19 pandemic response and to improve our response to future pandemics. The Prevent Pandemics Act was marked up and discharged, meaning it passed the Health Committee on Tuesday, March 15th. As the bill is supported and sponsored by both the chair and ranking member of the committee, it is widely expected to pass the Senate. Now I'd like to talk a little bit about our DEI initiatives. We're proud to say that our DEI work is predominantly member-driven, as part of a push that reached another level with our centennial last year. Much of this push is centered around equal opportunity to become a PT, and a lot of this drive actually came from our PT students. They're our future, and they're really motivated to make our profession match our vibrant country. Now, the DEI efforts led by APTA staff focus on PT education. We're leaders behind HR 3320, the Allied Health Workforce Diversity Act of 2021. This legislation, led by Bobby Rush and Mark Wayne Mullen in the House, and Bob Casey and Lisa Murkowski in the Senate, would provide stipends and scholarships aimed at supporting recruitment and retention of PT students from underrepresented groups. In addition, APTA has its PT Fund, which is actually broken up into two smaller funds. The first, our Minority Scholarship Fund, gives financial assistance to PTs from underrepresented minority groups. The second, the Dimensions of Diversity Fund, can be used to fund any DEI initiative across APTA. Next, I'd like to talk about community health centers, specifically our bill to get PTs out into rural and medically underserved communities. As I'm sure many of you know, current laws and CMS regulations require PTs to be CHC employees and to be reimbursed from CHC funds for services provided under Medicare and Medicaid. This creates an unfortunate amount of red tape for you all, and especially for CHCs who receive their Medicare and Medicaid dollars as a lump sum at the beginning of the calendar year. In order to address this, APTA endorses and is leading a bill, HR 5365, the Primary Health Services Enhancement Act, that would fix this issue. This bill would permit PTs to contract into CHCs and bill Medicare and Medicaid directly for services provided. This is a simple fix that will allow you all to more freely interact with CHCs without having to jump through regulatory hoops. This is a major priority of ours, so please, when you engage in your own advocacy, consider mentioning it to your member of Congress and senators. Now I'd like to talk about a related bill, actually, one that's closely partnered to our CHC legislation, and that's the National Health Service Corps. As many of you know, the National Health Service Corps gets care out to 17 million Americans across the country. Importantly, National Health Service Corps members are often from the communities they serve. Now, participants also tend to stay in these communities after they leave the program. One of the factors driving NHSC enrollment is student loan forgiveness. However, PTs cannot currently participate in the student loan forgiveness program. That's why we support HR 3579, the Physical Therapy Workforce and Patient Access Act. This bill would make PTs eligible for NHSC student loan forgiveness programs, getting care out to those who need it. And the reason why we've partnered these previous two bills together is to really highlight and hammer home the importance of PT in light of the opioid crisis and long COVID. You know, I know I'm preaching to the choir here, but physical therapy is one of the most important ways to combat both of these crises. And these bills are designed to get you out to underserved areas to have that vital care provided. Next, let's discuss prior authorization. So APTA supports HR 3173, the Improving Seniors Timely Access to Care Act. This legislation will establish an electronic prior authorization process to help ensure timely processing for items and services in need of approval. It would also require the HHS Secretary to establish a real-time decisions process for items and services that are routinely approved. Finally, the bill would prevent plans from requiring prior authorization on any additional surgical or other invasive procedure if this procedure is furnished during the perioperative period of an already approved procedure. Now, this is just a common sense bill that's designed to help you all do what you were trained to do, provide care to your patients, not cut through red tape. The last legislative topic I'd like to discuss with you all today is locum tenens. The COVID-19 public health emergency has shown us all the importance of continuous healthcare coverage, and I know you know how important locum tenens is for this. As many of you know, the 21st Century Cures Act of 2016 contained a provision that added PTs to the list of healthcare professionals who may use locum tenens under Medicare. Unfortunately, this extension only covers PTs practicing in non-metropolitan statistical areas, medically underserved areas, and health professions shortage areas as defined by HHS. HR 1611 would correct this issue, expanding the use of locum tenens under Medicare to PTs in all geographical areas. Finally, let's talk about the advocacy you can do on your own to complement our efforts here at APTA. You may ask yourself, what can you do? First off, you could find your member of Congress and your senators and reach out to them to express your concerns directly. You'll get these slides, and if you follow those links, you can actually find your members and your senators as well as how to contact them. You can also use the advocacy resources we provide through our website, apta.org/advocacy. You can also download our app off the Apple and Android app stores. Now, this app provides helpful summaries of the bills we support. It can direct you to your legislators and connect you to advocacy efforts. Now, this is a bit of an aside, but I'd be doing you all a disservice if I didn't stop here to emphasize just how important your personal advocacy is to our efforts. Before I joined APTA, I was a Hill staffer for over 5 years. While I was always grateful to hear from subject matter experts when they came to the Hill to discuss bills, hearing about the issues directly from constituents was so very important. When you all reach out to your senators and your members of Congress, they and their staff listen. Remember, at the end of the day, they are there to serve you. You are their bosses. So please reach out to your legislators, call them, write them. You can use the templates we provide in our action alerts. You can contact us for advice on how to approach it, or you can just reach out on your own. But please don't underestimate the importance of your voices as constituents and as someone living the issues that you're advocating for. And now that brings it to the end of my presentation. Uh, does anyone have any questions? I'd be more than happy to answer them.
Yes, I have a question.
Okay.
As far as DEI initiatives, are part of initiatives with, I guess, in the, did you call it the Smart Cares Act? Or I think I might have that mixed up.
The SMART Act is our PTA differential bill. HR 3322, the Allied Health Workforce Diversity Act, is the big diversity initiative we are working on in Congress right now.
And that's being able to attract more, diverse and inclusive population into the PT profession, correct?
Yes, that is correct. It's aimed to bring in PTs from underrepresented groups. That could be low income areas in general, that could be minority groups. One of the reasons why Mark Wayne Mullen is on, he is actually a member of a tribe from Oklahoma, so it's aimed at tribal groups. Just getting folks who aren't typically in the profession into it, and more importantly, getting them back to the communities they come from.
Okay. And is part of or included in that initiative, I guess earmarks for like HBCUs or smaller colleges and universities where it is you're able to help, I guess, bring in maybe mentorship or qualified professionals, or professors, when I say professionals, helping smaller schools who don't have PT programs initiate PT programs if there's an interest.
So this legislation is actually written to be very broad to make sure that as many underrepresented groups as possible are able to apply for, receive funding, and get involved.
Okay.
So it's designed to cover anyone who's low income from a medically underserved area, any minority group. We wanted to keep it as broad as possible to try to bring in as diverse an array of PT students and PTs as we could.
Gotcha. Okay. And my second question is, about student loans or student forgiveness programs for PTs, and advocating for that. Is there, and a lot of the stuff that I see currently for other healthcare professionals, it's almost worded like you have to work for an employer. You have to have an employer in order to be able to qualify. Is there something there for self-employed professionals that will be able to benefit as well?
So I don't recall any legislation off the top of my head. What I can do is I can circle back to our payments team to see if there are any student loan forgiveness programs for solo practitioners. At the moment, our biggest initiative is again supporting the National Health Service Corps loan forgiveness program. But again, for that to work, you would have to be in the Corps. It would be a
Mhm.
2-year contract and $50,000 forgiven for each year.
Gotcha. Okay.
But
Thank you.
yes, of course. But I will look into that and we will get you an answer.
Thank you.
Of course.
Thank you, Brian. And any other questions? Sorry to put you guys on the spot, but again, you always have the advocacy at apta.org. We have a ticket system where we get back to members in a very timely way. If you can't think of any questions right now, but have any further ones, when you're noodling on this later. Okay, well, hearing none, Brian, any last thoughts, or Lori, any last thoughts?
I'd say that my last thoughts were really to echo what I said at the end of my presentation, just to emphasize how important your advocacy is and for your members and senators to hear from you. I know sometimes folks say when they message their members of Congress and their senators, it feels like they're just throwing their email or their phone call into a black hole. I promise you're not. They hear and they pay attention. It's very important. So please keep that up. And to just echo what Steve said, if you have any questions that arose from this presentation, or if anything comes to your mind later, please don't hesitate to email advocacy@apta.org and we'll answer your questions as quickly as we can. And then I will get an answer about student loan forgiveness and we'll transmit it to Lori as soon as we're able.
Thank you, Brian. And on my side, I'd echo what Brian says. On the regulatory side, the agencies are required to review every comment, so formal or not. So some random Joe Schmo is submitting comments on the regulations.gov website, or us on formal letterhead. So it's really helpful when members take advantage of that and submit comments, both if we have template comments or on their own, if they're expressing their own voice. So just to let you know, comments are being heard, and we've actually encouraged that. And we've seen instances where our precise asks have been reiterated in the final rules. They have considered them, they have accepted them. So again, it's a very powerful tool to make use of. So I guess seeing no further questions, thank you so much for tuning in and listening to our presentation. And again, if you have any questions, feel free to email us at advocacy@apta.org.
Thank you guys so much for today. I did just want to throw out too, I heard, some of the questions related to how are we supporting diversity? And I know that was more at the federal level, but at the state level, our legislative agenda doesn't just include the, professional scope of practice. We have an entire social determinants of health and diversity agenda as well. And so things we are doing is, if you saw, our mentor program includes going out to local high schools where they would not necessarily have introductions to the profession, and we do virtual tours and on-site meetings with our STEM students. In addition, we go to pre-PT, PTA programs. We are specifically doing mentorship and also doing different educational sessions with HBCUs in Maryland. And on top of that, we're starting a scholarship to support students with diverse backgrounds to help them with their cost of education. So that'll be launching as well this year. So I just wanted to let you also know what's going on the state side.
Great.
Well, thank you, everyone.
Yes, thank you all so much for your time and attention.